Madam Secretary, great to see you. And thank you so much for coming tonight, and welcome to the Hill Center. We no need for an introduction of Secretary Sebelius. She is a great friend and a great person. I also want you to know, you may know she comes from great political stock, born in Cincinnati, the daughter of the governor of Ohio, John Gilligan. Then she moved on to Kansas, ran for the elected to the state legislature in Kansas, served as insurance commissioner in Kansas, and then was elected governor of Kansas, becoming thereby the first father-daughter governor pair in the United States history. And has further made history by being our 21st Secretary of HHS under President Barack Obama, with the awesome responsibility of first helping design and then helping enact, and now responsible for implementing and putting into effect the Affordable Care Act, a great, huge responsibility. If she looks familiar, also, it's not just that you see her on television. Secretary Sebelius lives on the Hill and haunts all of our favorite eateries on Capitol Hill. I often see her and her husband Gary at our local places here. So, Madam Secretary, great to see you. And we promise you tonight a warmer welcome than you got at Georgetown University.
Actually, the welcome was wonderful. Yes,
once you got there.
There was all the noise outside of Georgetown. Georgetown was great.
Well, I want to start there, because one thing that I've heard you speak about that's very important to you was, under the Affordable Care Act, expanding women's health and preventive care for women. Why is this so important, and how is it going, and what about these obstacles that people keep trying to throw in your path?
Well, first of all, thank you for having me here, and thank you, Diane, for having this at the Hill Center. I told Diane I haven't been in this building yet, so it's a thrill for me to finally come into the Hill Center. I go by it all the time. And I want to thank Rick. Rick does a great job at our Agency for Planning and Evaluation. They're sort of our think tank and help us figure out big issues and problems. Women's health care was often neglected in the health system, and as a former insurance commissioner, I used to see these policies, and it frankly drove me a little crazy that in the early 90s it was very typical for policies to cover Viagra, 90%, 95% covered Viagra in their prescription programs, and 25% covered contraception, the most commonly taken drug of women 14 to 45. So it seemed like it wasn't a very, so women not only did not have access to some of the prescriptions they needed, but often the health services that women needed weren't in insurance plans. So women paid more in the insurance market, often 18% more if you were buying your own coverage than did their male colleagues for exactly the same coverage. And then what women needed in terms of health services, everything from prescription drugs, mental health services, domestic violence screening, lactation help, various things that kept women healthy along the way were not in the insurance plan, so then they paid more out of pocket. So they paid more for the policy, and then their out-of-pocket costs often were 50% higher. So one of the issues that Congress looked at in the Affordable Care Act was not only were there some basic services that should be part of everybody's policy, but then were there gaps in services for children, for women, for others. And in women's health, we were asked to recommend a set of services. We did not do that in the Department of Health and Human Services. We turned to the Institute of Medicine and asked them where the gaps in the policies were. So they came back with basically 8 different categories. And those will become part of preventive services that will be part of insurance plans offered with no copay and no co-insurance.
And they are in place, or?
Starting August 1st, for plans that are in the private market, when the plan year is renewed after August 1st, a lot of plans are renewed in January, but there are various times during the cycle. So beginning August 1st, 2012, next week, insurance plans will begin to include these services as part of the package. And employees and individuals will have options to take advantage of that without, again, the whole notion of having preventive services without copay or co-insurance is that we really want to keep people healthy in the first place. So having a financial barrier as a possible hurdle to getting your kids immunized or to getting a mammogram, or in the long run doesn't make any sense, because if someone gives up getting an early cancer screening because they don't have the copay, only to find out a year later that they have cancer but it's further advanced, they're going to spend a lot more and potentially even face death. So the whole effort is to move to a system where people actually can stay healthy in the first place. So starting August 1st, that goes into effect.
And we will have time before the Secretary leaves, a few minutes for questions, so hold your questions if you will. Madam Secretary, just about a month ago, the Supreme Court decided that the Affordable Care Act was in fact constitutional, maybe not along the same reasoning that we expected, but they came to that decision. Were you surprised at that decision, and what do you think what is its impact? How do you read its impact?
Well, it was 4 weeks ago today, but who's counting? That the court actually issued a decision, and I was cautiously hopeful that they would find the law constitutional. The lawsuit was filed the day the president signed the bill into law. So on March 23rd, 2010, the first of what were a series of lawsuits were filed. So we've sort of been, we've been implementing full steam ahead, but under the shadow that the court decision would be the ultimate arbiter. We had 5 appellate court decisions. 3 of the 5 were favorable. 2 of the 5 were found the mandate unconstitutional. Only 1 judge in the 15 who looked at it suggested that the whole law would be struck down. So 4 of the 9 Supreme Court justices found that the whole law should be struck down, which gives you a little bit of an idea of where they are on the ideological spectrum, because those 15 judges, some were appointed by Democratic presidents, some by Republicans, they were all over the country, and only 1 of the 15 thought that that was the appropriate remedy. But the fact that there now is I think a pretty significant green light to moving ahead clears up, I think a major hurdle to getting states to fully implement state exchanges, people being somewhat confident that the benefits that are now in place will stay in place and become part of the plans, and that companies will have some certainty as they look toward the future of how to frame the market.
Do you think it makes it more difficult? People of the other party are continually talking about repeal. Mitt Romney says the first thing he wants on day one of it, were he elected president, he would repeal the Affordable Care Act. It's more difficult now, isn't it, with the Supreme Court?
Well, it certainly takes away a huge argument. I mean, I think this debate would be very different if along with the politics, you would also have the Supreme Court saying a portion of the law, or a major portion, was unconstitutional. They did find one portion of the Medicaid expansion unconstitutional, and that really is this gets a little technical and I apologize for this, but the law basically assumed that every state in the country would expand Medicaid up to 133% of poverty. I know most of you don't carry around those federal poverty charts in your head. 133% of poverty is for an individual, somebody making less than $15,000 a year, or for a family of 4 making less than, $31,000 a year. So we're talking about really some of the poorest adults in the country that are working, but they are pretty poor. Right now, states set a level of Medicaid. So depending on where you live in the country, if you're not a child or a pregnant woman that have kind of universal levels set, you could be incredibly poor and still not have access to any affordable coverage. So this said up to 133% of poverty, everyone, regardless of where you live in the country, should be Medicaid eligible. But in exchange, the law also said the federal government would pay the lion's share of those newly eligible, not only now, but into the future. What the court found was that formula is fully constitutional. What is not constitutional is the possible penalty that if a state were not to take up that offer that the federal government could then take away all of their Medicaid funding. That actually is a penalty that's in the existing Medicaid law. And they said you really can't threaten a state with the loss of billions of dollars. This is really a new program and a newly enrolled group, so it becomes a voluntary measure for states.
Well, and I wanted to ask you about that because the Congressional Budget Office just last week found that implementation of the Affordable Care Act will actually save us money, if you will, $84 billion over the next, I think, 10 or 11 years. But that's like maybe the good news. But the bad news is the way they save money.
Well, they're estimating now, because this becomes more of a voluntary program, that some states will actually choose not to do that, or at least not to do it on day one, that they would delay coverage. We're, I think, more optimistic than CBO. The Children's Health Insurance Program expansion, which was, again, part of Medicaid. If you're a poor child, you would qualify for health insurance, voluntary for states, a higher federal matching rate than the typical Medicaid. And there was a lot of protest from governors originally saying, oh, we're never going to do that. This is a really bad idea. I have no interest in doing that. And within 3 years, every state was part of the program. So this is actually a much more generous federal-state arrangement. So I'm hopeful that I think there will be a lot of governors who will wait till the election. And I'm hopeful that when the president is successfully reelected, then this debate might be over.
You may have said, if you did, I missed it, I apologize, but you did say this, the federal government picks up the vast majority. What is the percentage?
There's a 10-year formula in the law. It's 100% for the first 3 years. It goes to 97%, and the lowest level it gets at the end of 10 years is a 90-10 match. 90% federal government, 10% of the state.
So the states are getting 90% of cost of expansion covered by the federal government.
And ironically, the states who have the lowest level of people insured have the most to gain. So Texas, you hear a lot from Governor Perry, who I served with in Texas, who says, you know, never under any circumstances would he ever consider this for the state of Texas. 25% of the citizens of Texas have no insurance coverage at all. 25%. So it's the highest level of population that has no insurance. And what this deal basically says is if those people are below 133% of poverty, basically the federal government would pay the lion's share of providing that coverage. I think at the end of the day, that becomes a very tough deal for a governor to turn down, and you know, it isn't really our conversation to have with the governors. It's the citizens in that state, the hospitals in that state, the doctors, because they're right now serving a lot of people and not getting paid for it, providing what's called uncompensated care. So hospitals are on the brink of bankruptcy, people, you know, doctors don't get paid if they deliver services, and that conversation, I think, will be active and underway in states around the country.
It seems that everywhere you look these days, there are stories about the Affordable Care Act. It is a signature achievement of the Obama administration, getting a lot of attention. And there's a story today, actually, in Politico, that reports that the president, when he's out on the road, or either a campaign event or other public events, he always brags about the Affordable Care Act, rightly so, says how proud of it is, we did the right thing. Politico reports that he spends more time talking about how important it is when he's speaking to minority audiences, African American and Latino audiences. I don't know whether you have found that, but if he does, there's a reason for it, isn't there?
Well, we have not only a significant gap in insurance coverage, and that minority communities tend to have less insurance right now than the majority community. But we have a huge gap in health disparities that's directly linked to that. So you're more likely to die of a heart attack if you're African American. You're less likely to get preventive care. You're more likely to have a child with diabetes, to have HIV/AIDS, to suffer from any number of chronic diseases. And the mortality rate is higher in minority communities, in African American and Hispanic communities. So if you look at, I mean, we just had, as you know, in Washington, all of you know, that Washington has been the host to a worldwide HIV/AIDS conference this week. We have 25,000 people in town from around the world who are here for the first time in 22 years, because up until 2 years ago, the United States had a travel ban. So if you were HIV positive, you couldn't get a visa to come into the United States. You couldn't travel to this country. That travel ban has been lifted. It was part of what was implemented in the early 80s, and when people were very confused and terrified about this disease. Nobody really knew how people got it. There was a lot of stigma, and one of the things we did is just say, you know, we're going to lock our borders to anyone who is HIV positive. But if you think about, you know, that's now more of a chronic disease now that there are effective antiretrovirals. But if you don't have insurance, if you don't get screened, if you don't have a way to pay for that antiretroviral treatment or have access to care, it's still a death sentence. And that's the situation with a lot of chronic diseases. I mean, so insurance coverage links directly to, I think, groups and people who have a better lifestyle. In fact, there was a recent article, I don't know where it was, but that indicated that states that have actually expanded their Medicaid coverage, so again, the lowest income citizens in that state, and they now have insurance coverage, have reduced the death rate. I mean, this is really a life or death issue for a lot of people, because if you don't have coverage, you don't have a way to get regular care, and you have any kind of a chronic illness or disease, you really can be in a very difficult situation.
One of the things that I've been curious about, with all the new provisions and all the new opportunities that are available to people now, how do you count on people, or do you count on people knowing about what's available and what they can get, and if not, how do you get the word out?
Well, that's a constant issue in our department. I mean, we have, you know, websites and flyers. I mean, one of the things that I think is somewhat complicated is that this law is being phased in over time. And so some provisions are in place right now, some are not going to be available until 2014. So keeping people kind of up to speed. And what we find is that it's easier sort of to describe what's happening in the law by population. So there's a lot of information going to Medicare beneficiaries about what Medicare now has in place that wasn't there before, and what's coming in Medicare. That's very helpful, and it's helpful to that population, but not necessarily if you're 26, and you know, that might be interesting, but people's eyes glaze over. So the 26-year-old needs to know that he or she and their younger brothers and sisters can stay on the parents' insurance plan up until the age of 26. Again, a benefit of the law that wasn't in place. So we have 7 million more young Americans who have insurance today than did 2 years ago because of that provision, because it was easy to expand their parents' policies. Their parents who have a child with a pre-existing health condition, those laws have changed, so insurance companies can't any longer lock that child out of coverage. We have people all over. Did any of you get a rebate check or notice? Did we talk about that earlier?
We talked about that a little bit, yeah.
But I mean, I'm getting calls from friends around the country, and my brother called me the other day and said, I just got a check from my insurance company. And luckily that, I mean, we actually helped to write the notice that the insurance companies had to send, which says, you know, I didn't meet the medical loss ratio this year, this is why, here's how much I missed it by, and here's your money. I mean, who ever heard of getting a check from an insurance company, for heaven's sakes? But that is a national, you know, program that what we have is companies for the first time adjusting their administrative costs and bringing them down, providing more health benefits. We're seeing people for the first time ever having to be very transparent. Nobody ever knew why, you know, you'd get a notice saying your premium's going up 15% or 20%. Nobody ever knew why. You could never find out what was inside that premium that might be driving costs. Now they have to report that data, and we put it on a website, and we compare them to other companies. I mean, this is kind of a brand new day. So it is, there's a lot going on. There's a lot of exciting things, and again, I apologize, I don't know what Rick covered, but one of the things that has nothing to do with the insurance market. A lot of the conversation about the Affordable Care Act focuses on the market and, you know, new rules and whatever. I think some of the most exciting transformation that's underway is really in what's called the delivery system. So what happens to you when you actually go to a hospital or
just so you know, Rick did not get to this, so this is new ground.
So Medicare is the largest insurance company in the world, basically. There are about 50 million beneficiaries, and about over $1.25 billion a day is moved to providers, hospitals, drug companies, medical device companies. I mean, it's a big operation, and it touches basically every hospital, every doctor in every state. So Medicare can either be a program where using those financial resources can encourage innovation, reward best practices, look at what's happening, and try and find ways to keep people healthy. Or we can do what we did in the past, which is basically pay by volume. You do more stuff, you get more money. You run 15 tests, you get paid 15 times. You spend more days in the hospital actually makes more money, including the 100,000 people who get a hospital-based infection. When they get to that, not what brought them to the hospital, but they get an infection in the hospital, causes them to stay more days. That actually, you know, bodies in beds get paid more. If that bed is empty, that hospital makes less money. So we had all the financial incentives in all the wrong places for not looking at what happened to the patient, or what are the best results, or what the protocol that cardiologists said should be followed every time, and if this doctor follows it or not. It really was based on how much you do, a volume-based system. So part of what we are charged with doing now under the Affordable Care Act is really looking at strategies to capture the best practices from Mayo Clinic and Geisinger and Cleveland Clinic that we know are actually not only better care strategies, wrapping care around patients, looking at, as they call, bundled care, so complicated patients actually who have multiple doctors. Those doctors talk to one another and coordinate the care as opposed to having the patient go to 15 different places, and begin to use our financial levers to encourage those practices every place. So capturing the best practices, and we are going to start actually measuring hospital-based infections and putting hospitals on notice that we know this is an area where they can do a lot better. There are some hospitals that have almost completely eliminated infections in various strategies, and others that run at 15, 18, 20%. Now, you all don't know that necessarily. You know, you go to the hospital down the street or around the corner, you could have a similar hospital across town with a very different infection rate. Wouldn't you like to know if you're going to a hospital where 20% of the patients actually end up with a hospital-based infection, and that could make you much sicker in the long run?
I think it might influence your decision.
But payment has a good deal to do with those kinds of issues. So the strategies are really to encourage the best care. And again, it's not, people at HHS aren't making this up. This is really care strategies that are put together by healthcare providers, run by the best systems, and that we will capture those practices and then begin to reward. First, teach other people how to do it. A lot of technical assistance, a lot of help and advice, but then actually begin to pay people differently depending on what kind of care they deliver.
So I have one more question, and we'll have time for just maybe a couple quick ones before the Secretary has to move on. Madam Secretary, you had an announcement at the White House today with the Attorney General, which kind of relates to what you were just talking about, perhaps cracking down on fraud in the system. Where and what's the problem? How serious is it? And what are you doing about it?
Well, again, another unknown fact about the Affordable Care Act is that it's probably the toughest anti-fraud legislation that's ever been passed. It gave our department not only a real directive to spend a lot more time and focus on fraud, but also gave us some new tools. So criminal penalties were doubled. We have resources to build a predictive modeling system. This is the kind of computer system that credit card companies use. So if you get a call from MasterCard saying, I see that your bill has 5 flat screen TVs from Abu Dhabi and you don't have any purchases from Abu Dhabi in the last year, is this your purchase? And you say no. And they don't pay the bill, and then they track that down. We didn't have any capacity to do that. I mean, remember my earlier comments that Medicare moves $1.25 billion a day to providers and hospitals. We have almost 1 billion registered Medicare providers, doctors, hospitals, device companies. So there is a very complicated billing system, a lot of money moving back and forth. A lot of fraud going on, particularly around certain kinds of strategies and in certain areas. So we have now put together a modeling system where people can look real time at claims and look at what errant billing practices. So what we saw in South Florida is durable medical equipment bills that were 4 times as high as any place else in the country. It sets off a little alarm bell because now we can see that in real time. We have strike forces now in 20 cities around the country made up of U.S. attorneys' offices and special investigative forces. I mean, some of these criminal activities are pretty sophisticated because there's a lot of money. So setting up a fake office, stealing or paying patients to use their Medicare cards, so you have billing numbers, and then just starting to bill for services never delivered. And in some cases, services that were never needed, drugs that are given to people that have put them in very serious life-threatening situations, equipment that was never bought. We have returned, so the President charged the Attorney General and me with when the Affordable Care Act was passed, was actually taking this up to the cabinet level. We finally have now a deputy secretary in the department who is in charge of a fraud unit and in the Medicare system. He's a doctor and a lawyer, and his expertise is fraudulent activities, and he is helping to put together a system. Today's announcement that Bill's talking about was to announce a partnership with private insurance companies, because they're often looking at the same kind of criminal activity, and we're actually going to have a data sharing arrangement so that if they spot fraudulent activity on the private side, they will share it with us and vice versa, so we can be more efficient. We, last year in 2011, returned $4 billion to the Medicare Trust Fund from fraud and abuse activities that were then, people were either put in prison, we settled claims, and that was a record number, but we think we're still just scratching the surface. But the goal is to really make, we used to run fraud activities on what we called the pay and chase system, so you'd send the claims out the door, find out 6 or 8 or 10 months later that there was fraudulent activity, then you'd go try to track down, often try to find people who were long gone. They had moved someplace else or changed their mode of operation. This goal is really to spot it at the front end, to prevent it in the first place, or to get much more nimble in terms of cracking down on this stuff.
It's just amazing how many dimensions, different dimensions are and aspects of this law. Not to mention all the rest of your work, too, that you've got in the department. A couple of quick questions, Madam Secretary. We're going to start right here in the front. We'll come back to you. Yes.
Great job getting the law enacted. Terrible job explaining to the public so it's
I'm going to repeat this for the folks in the other room, the overflow rooms. The question is, great job getting the bill passed. Not such a great job. I'll just soften it a little. Not such a great job selling it and explaining it to the American public. What can you do, Madam Secretary?
Well, we're working on it every day. I think it's a lot easier now that there are some benefits in place. And I don't know if you had an opportunity, but there was a lot of education done leading up to the Supreme Court case in the last 2 months, and they were able, in pretty practical terms, to really say, here's what's in place and here's what you'll lose. That's a lot easier than sort of the theory of you might get this and somebody else saying, constantly pitching misinformation. That's still going on. I mean, there were a couple $100 million in paid advertising backed up by 24/7 talk shows, really making things up from the moment this debate started, and they're relentless. I mean, it still goes on. So part of it is drilling through what's not there, and part of it is connecting people to benefits. But I agree with you. We got to do a better job, and we got to do a lot better outreach.
I got to say, I saw maybe a couple of weeks ago on the tube a spot, and it was about healthcare, and I thought, oh, here they come again, you know, with death panels or something. But the spot was outlining, you could qualify for this, you could qualify for this, you could look into this, and I believe it was sponsored by the department. And I thought, yes, what we need. And it was great. Yes, Matt, right.
Yes, thank you so much. My name is Dr. Michelle Ogle, and I'm actually an infectious disease specialist and an HIV provider here for the International AIDS Conference.
Oh, good. Oh. From where?
From North Carolina.
Good.
From very rural North Carolina. And first of all, I want to say thank you so much for all your leadership and work that you do for us and allowing us to provide services for people living with HIV. We appreciate all the partnerships you formed. It's made a huge difference in your leadership on the first national HIV/AIDS strategy. So as a provider and a Ryan White provider, a lot of us are concerned about the Affordable Care Act and how it interacts and how it's going to affect Ryan White, particularly Ryan White Part C, which is dear to me because that's how we provide primary services. Can you please speak to that for me?
Sure. This is again a little detail, but the Ryan White Act is a law that was passed specifically to provide services, support, and care for folks who are HIV positive, and has a whole series of resources, a drug program for antiretrovirals, wraparound health care, and it's run really at the state and local level. Some of what is provided in Ryan White will now be provided when people actually have their own insurance coverage. But Ryan White is up for reauthorization, not this year, but next year. And that conversation is very actively underway of what kind of services will now be duplicated and what kind of services will still be needed. What's the wraparound care look like? We have a great, though, snapshot, because in Massachusetts, we have exactly this strategy. So Massachusetts now has 97% of their citizens insured, and the Ryan White program is still very much in place. Some of the members of the President's Advisory Council on HIV and AIDS are actually Massachusetts healthcare providers. So we have a whole committee who is working with our department and agency to really look at where the duplications are, where you could eliminate funding, and what really services and support are needed. So we'll, I think, be in a great place to make strong recommendations to Congress prior to 2014, which is when a lot of the insurance benefits will come into place, but know well that the worst of all worlds is to decrease services and support. What we want to do is increase them, but I think Massachusetts will give us a roadmap of how to do that.
Thank you.
Okay. Yes, sir. All right, in the back. And this has to be the last question, I'm told. Yes.
So, Madam Secretary, I know that you anticipate the President's re-election, but should Governor Romney be elected, what are some ways that his appointed secretary might stymie the progress of the act? And perhaps moreover of greater importance. Is there anything that can be done now to sort of preempt that?
All right, so the question, which I should not allow, is based on the premise that Mitt Romney were elected president, which of course is not going to happen because we won't let it happen. But the question is, if that were the case, what could a new secretary do to thwart the Affordable Care Act, and what could you do now, Madam Secretary, to make sure that it's impregnable and they can't get to it?
Right.
Well, I think let's start with the second part of the question. There's virtually nothing we can do now to lock into place provisions that won't be realized till 2014. So there's no way to sort of fast forward and make the law solid. I think it isn't so much what a future Secretary of HHS could do, it's what Congress and the President would do. So if indeed Congress shifted along with a shift in the presidential regime, you would have a bill that then could go through Congress to repeal all or parts of the law, and it would be signed by the President. If you have President Obama reelected, regardless of what happens with the congressional makeup, if a repeal attempt was successful in Congress, you would still have a veto. And so you would have to have 2/3 of the Congress change, in order to repeal the law. It's a very different scenario if you have a Republican House, which we do right now, if you would lose a couple of seats in the Senate and then have a president who would sign that into law. The whole thing could be gone. And there's really no way to lock in not only things that aren't yet in place, but retroactively to say that the new Medicare benefits would stay, or that the fraud issues that I've just described would stay, or that any of the pieces would stay. So I think the whole thing is very, very much at risk depending on what happens in the presidential election.
Sounds to me like one more reason to vote, and to vote the right way. Madam Secretary, thank you for your leadership. Thank you.